Welcome, everyone. I'm sure a few people will start coming in as well, or popping in. But I just wanted to start by welcoming everyone. This session is entitled A New Framework for Methadone Carries, a person-centered evidence-based approach to take-home dosing post-COVID. And this talk or session will be put on by Vincent Lamb, Andrew McLeod, Charlotte Munro, and Jennifer Wyman. There's also other authors involved in the guidelines as well. And I'll just read out everyone's bio and let them begin. So Vincent Lamb, Dr. Vincent Lamb completed his medical training in Toronto. He has worked in emergency medicine and addictions medicine. He is a noted author, columnist, and an executive editor of Opiate Agonist Therapy, a prescriber's guide to treatments. Suzanne Latreille works as a peer educator for the city of Ottawa. She was introduced to the harm reduction field 15 years ago by a friend and social worker with her local community resource center, who suggested that she become a peer worker as a way to support her own recovery. 1 week of sobriety has turned into 12 years, and Sue is grateful for the positivity and faith of those who have helped her along the way. Andrew McLeod is an individual with lived experience with addiction, specifically with OUD, and who received OAT for nearly 2 decades. Andrew brings his experience with harm reduction, with patient-centered care, as well as with the challenges and successes of OAT. Charlotte Munro is a child and youth worker providing independent program facilitation in Stratford, Ontario. As a person with lived experience, she enjoys doing patient engagement and collaborative work. A leader and member of local boards and committees, Charlotte is passionate about advocacy that addresses social injustices. Jennifer Wyman is a medical educator with PHI, medical director of the substance use service at Women's College Hospital, and an assistant professor in the Department of Family and Community Medicine at the University of Toronto. Her interest is in building equitable and integrated healthcare for people who use substances. Maria Zhang is an advanced practice clinical leader and clinician educator jointly at the Center for Addiction and Mental Health and at the Leslie Dawn Faculty of Pharmacy, University of Toronto. Maria completed her graduate work at CAMH through the Department of Pharmaceutical Sciences and the collaborative program in addiction studies at U of T. The focus of her research and her teaching is substance use disorders, with a specialization in problematic knowledge translation and supporting the continuing professional development of healthcare practitioners. Thank you.
Thanks, Rachel. We're really happy to be here. Just briefly, in terms of disclosures, this program received support from PHI in the form of stipends to the guideline group members for their time, as well as in-kind support, lots of logistical support, particularly from Sarah. And with regard to our individual disclosures, Sue is not with us now. I don't think she has any disclosures to share. Vincent?
Yes, I've received an honorarium from the University of Waterloo for a public presentation. I've also received an honorarium from the provincial government of Alberta for expert consultation.
Andrew?
Hi, everybody. I don't have any disclosures to present. Thanks.
Charlotte?
I have no disclosures to present.
Great. And I have no other disclosures to present either. So we're going to jump in. We have a lot to try to cover in a short period of time. I'll just say that we've posted a link to our document, which is a draft document on a new framework for decision-making around carries. So we invite you to open that and have that beside you. There's a summary document We hope that you will not go straight to the summary because it's everything that is sort of makes up the meat of the discussion that we feel is really important. And the summary is sort of a cheat sheet at the end of that. This is really our first opportunity to share this work with a broader audience. We're really excited to looking forward to getting feedback. We're going to spend the first half hour or so going through the process and the rationale coming to this framework. And then we'll break into two groups and use a couple of cases to try to apply the framework. I'm going to ask you to put comments or questions in the chat where Rachel will be monitoring them. And if there are things that look like they need to be addressed within this first half hour, we will. But otherwise, we're really hoping that we'll have an opportunity to address questions and comments within those case discussions. So just setting the stage for this work, we want to say very explicitly that everyone involved in this looks at OAT as an important harm reduction strategy and does not come to looking at methadone or OAT as being a necessarily abstinence focused therapy. Now more than ever, we see OAT as being a very important harm reduction strategy. The recommendations in this draft are not sort of your classic grade review of the literature for a variety of reasons, including the fact that there's not a lot of strong literature looking at caries specifically. But it includes the collective experience of the group as well as our literature searches. And the group, as you can tell, and this is really critical to the work, includes prescribers, pharmacists, and people with lived experience of OAT. The intent of this work is really to establish a framework that tries to balance the need both for structure and for flexibility, both for providers and perhaps even more importantly for people on methadone. We recognize that the focus on using clinical judgment in terms of decision-making has benefits, but is also fraught, probably both for providers and for people on methadone if there's not enough guidance or structure to create the framework or the necessary sort of objective measures for that decision-making. And I also want to say that this document applies specifically to methadone, not to buprenorphine, because there's already much more flexibility around buprenorphine take-home dosing, and not to SROM at this point because there are more restrictions typically around SROM, which is still being considered third line. And while new guidance documents around SROM prescribing are being developed, we expect that those will address caries as well. So we look forward to feedback. This document will be shared for feedback by a range of stakeholders, and that feedback will be synthesized and turned into a final document over the next few months. In terms of background and the intersecting events that have prompted re-examination of the previous carry guidelines, we're obviously living in very, very concerning times, and the increased rates of overdoses related to opioids and the toxic street supply are hugely concerning, making not just access to OAT, but retention in treatment more critical than ever before. We've also had the opportunity to learn from practice changes during the pandemic when increased flexibility to take-home dosing was implemented quite broadly in order to support public health guidance. And then in 2021, as we know, the CPSO MMT guidelines were rescinded. And while there are some positive things around that, trying to make methadone practice more in line with other kinds of practice and potentially reducing some of the stigma and barriers, both again for providers and for patients, it also leaves a void and a situation in which many people are still practicing in line with the old guidelines, and others are looking for ways to apply that new freedom to use their clinical judgment. And then finally, we need to acknowledge that people with lived experience of OAT have historically not been included in the development of treatment guidelines. And as the people who most bear the burden of those guidelines and have the experience to guide us, their voices need to be heard. So all of those things came together as we thought about forming this group. I'll talk about the terms of reference in a moment. The group, as you can see, includes equal numbers of people within the healthcare professions and people with lived expertise. And that was really important to us in thinking about the numbers and some kind of parity, but also making sure that no one in the lived experience group felt like they might need to be there as the sort of token representative of the group. We also decided early on that we needed to have a moderator just to make sure that everyone really felt heard through the process. And Sarah Clark was our moderator, who also was able to take time to meet with people outside of our larger group sessions. So as we reviewed the literature on these topics, we met together approximately every 2 weeks from March to the beginning of September to review the evidence. Again, both the literature evidence and the experience of people within our group with experience to continue to formulate our thoughts. I'll just leave that for a moment. I think I already spoke about the process in terms of our review and having Sarah as our moderator. And I just want to say that it was really an extraordinarily positive experience for me, and I hope for the rest of the group as well, in terms of being an opportunity to really open ourselves to hearing about different experiences and ways of looking at methadone care and ways of sharing and utilizing knowledge. So I think we all know that the CPSO approach to carries probably represents approaches to carries across the world, although the specific details may differ. They seek to balance the risks of methadone to the person receiving the prescription and to the public, along with a second purpose of using carries as contingency management to motivate or incentivize abstinence from substance use. So we thought we would start with looking at the risks that go along with methadone as a medication, as a molecule, and with carries specifically, since that's really been a core priority for prescribers, understandably. And of course, there are risks associated with any opioid being prescribed, but greater risks with methadone because of its long half-life and its narrow therapeutic index. And so the concern is what happens if methadone becomes accessible to people for whom it's not prescribed because carries are improperly stored, lost, stolen, shared, traded, or sold. And in fact, we know that this happens, not infrequently. This study of illicit drug deaths in BC between 2015 and 2017 showed that of people or of dissidents in whom methadone was relevant, almost 40% did not have a methadone prescription of their own in the 60 days prior to overdose. So those are people who accessed methadone outside of a prescription. And the number is actually quite a bit higher in Ontario. Between 2013 and 2016, so this isn't super current data, but almost 90% of people in whom methadone was detected on toxicology did not have a prescription for methadone at the time of their death. Now, clearly we know that fentanyl is responsible for almost 99% of opioid and related deaths at this point. But at the same time, methadone continues to be present. And the challenge is trying to understand the proportion or the situations in which methadone was prescribed or unprescribed. We also know from looking at the literature on diversion globally that it happens. Some would say that prescribed medications that have psychoactive benefits and restrictions put on them will always be diverted, and that the challenge is how to minimize the risks of that. But rates range from about 5 to 34% of people on methadone reporting ever having sold their carries. And we also have a little bit of a window into that through the study that was authored by Kim Coderix in 2021. This was a survey looking at people receiving methadone carries during the pandemic. And people who, so this was an anonymous survey, people who had reported receiving carries prior to the pandemic, so presumably under the CPSO guidance, you can see, despite the stringency of those guidelines and our thinking that that protected against diversion, reported pretty significant numbers of carries being shared, traded, or lost. So Andrew, I think, is going to talk a little bit about what some of the other risks of restricted access to take-home carries can be outside of the risks of diversion and opioid exposure. Andrew, do you want to unmute?
There we go. Can you all hear me now? Thanks so much, Dr. Wyman. So as a group, when we sat down and we looked at the effects of restricting access to carries or take-home doses, the most common reason that came forward in regards to individuals who were seeking methadone outside of a prescription, that's to say diverted doses, illicit methadone off the street, had to do with their inability to get their own regular dose that they would get at a pharmacy. And there's a variety of reasons that reflected when I reflected back on my own experience. I used to attend a pharmacy that was open on a Saturday or a Sunday. On Sunday, it was open for 1 hour. And it was a regular occurrence that I wouldn't be there for that 1 hour due to a variety of reasons. Sometimes it was, not being able to get there at that time frame. Other reasons that came up, we've got individuals who have childcare or who are trying to work, and restricting access to take-home doses has a definite effect on the individual. First and foremost, that they will have withdrawal symptoms in an individual then seeking methadone outside of their prescription. The impact of restricting take-home doses really has an impact beyond just the fact that an individual is going to go into withdrawal. Looking at how this impacts an individual's ability to grow and succeed, and to be retained in the OAT program. I mean, as you were talking about, Dr. Wyman, we're sitting there in this virtual epidemic where people are dying. And OAT, for me, was the single greatest saving grace that it allowed me to, I guess the best way to put it is that it saved my life. So we want to ensure that individuals who are on this program are able to have access to achieve their goals and have a way of life. What we're looking at here is a quote, and it's something that I actually wrote, and I wasn't expecting it to be in the presentation, but it was included, and it speaks to how I felt when I went through my life, my 2 decades while I was on OAT. We're approaching Thanksgiving weekend, and it made me think back to a couple of decades ago when I was unable to go and spend time with family. I was unable to take on jobs that would be out of town. And the new framework that we're looking at is trying to make the program and access to carries more accessible so individuals can grow, can succeed, can be successful in living a life while on OAT. Thanks.
So we've talked a bit about the risks of carries, the risks of restricting access to carries, and then we think about what are the benefits of carries and how carries have been used. Just really briefly, there is pretty strong evidence for contingency management in substance use, and some of you may have attended the talk yesterday on contingency management, but just to highlight that literature really focuses on the use of a financial incentive, a token, a gift card, or some other kind of reward to incentivize the desired behavior. And the literature around using methadone or using the medication itself as contingency management is much less clear. These studies are reviewed in the document. In the interests of time, I think it's important to say that there is some, but not very strong evidence that using carries to incentivize abstinence actually works. And in some studies, there are increases, but not statistically significant increases in clear urine drug screens, and in others, there are not. But outside of abstinence, there are other benefits that have been shown with contingency management: improved retention and treatment, the opportunity for people to participate in work and recreational activities, and improvements in the therapeutic alliance that people experience. And then most recently, we have a few studies during the pandemic changes that have also helped to shed light on these changes. The study by Walters et al. Was actually led by David Frank, our keynote speaker yesterday. And this was a series of interviews with people on methadone in New York City, who shared that having increased flexibility around take-home doses allowed for a better balance in their daily life and managing their responsibilities. I already alluded to the survey by Kim Corrèze, in which people also talked about the benefits of carries in terms of openness and improved relationships with their providers, reducing their risks of exposure to COVID, and the opportunity to save time and money. And to me, perhaps the most significance of these studies is the one by Tara Gomes and group, which was actually published in JAMA. And this looked at data from ICES, NMS, and a number of other databases that showed that contrary to the concern about increased access to take-home doses being associated with increased overdoses, people who had not previously received carries, but did during that window in the summer of 2020 actually had lower risks of opioid-related overdoses, lower risks of treatment discontinuation, and lower rates of treatment interruption. So we thought that we should look at the Ontario OET guidance, since that probably sort of helped to form the approach to carry prescribing during that period. This was a document that was put together very quickly early in March 2020. Vincent's name is on there. It was a group of prescribers and pharmacists, and I'll acknowledge that it did not include nurse practitioner prescribers or people on methadone. And that was a gap in the design of the document. But briefly, it provided a ladder for increasing carries for people who already had some. And it suggested that people who didn't previously have carries could receive up to 3 non-consecutive carries per week, as long as they were not unsuitable. There's a lot of negatives here. Not suitable for carries was considered to be people who were acutely unstable in terms of mental health conditions, who had had a recent overdose, who were using substances in high-risk ways, such as high-risk alcohol and benzodiazepine use along with methadone, or injecting fentanyl. So we thought that as a starting point, we would look at those to begin an approach to thinking about how to use the evidence around the benefits of carries and the evidence emerging from this literature to help design a new framework. And I think, Andrew, this is your slide, actually.
Yeah, it is. Thanks, Dr. Wyman. So as a group, we sat down and we discussed some of the assumptions of the new approach to carry management. The first one is that having an increased access to carries has an impact that goes far beyond an individual simply reducing their substance use and achieving abstinence. That's to say, if an individual is more likely to have the ability to work, to live a well-balanced life, to be able to take their kids to and from school, or to, I mean, when I think of myself, I often felt handcuffed to the program. That's to say, having to be at a pharmacy at a particular time of the day. And that limited my ability to live a well-rounded life. The other aspect that we looked upon is how this affected patient-centered care. And that's to say, an appointment not simply being a check-in with a physician where I'm coming in and everything seems to be determined by a urine screen. That's to say, if I'm able to have an open and honest conversation with my physician, discuss what my goals are when I come in, and then working with my physician to be able to take some actions and that might involve referrals and some assistance in actually achieving those goals. And that goal might be abstinence. It might be long-term abstinence, or it may be honest about my desire to be able to use certain substances on occasion without the fear of my carries being removed because I chose to use a substance on occasion. Thanks. In that, you can move ahead there, Dr. Wyman. What we did is, no, I think this one's yours. Sorry about that.
I think it ties in with what you were saying in the previous slide, in which we looked at how to sort of turn those assumptions into working principles and a framework. And we really wanted to focus on the fact that decisions about carries, of course, need to be made in a conversation in an individualized way that looks at someone's ability to keep their carries safe, to take them appropriately, and that are going to help someone develop their stability. Smaller number of carries, we're called that up to 3 because that can be non-consecutive in a week, can be used to help someone build that stability outside of a contingency management framework. And we want to look at, we will in a moment, obviously, who meets that criteria. Whereas larger number of carries, 4 or more, would typically be reserved for people with greater stability. And I do want to say that part of what we heard from people within this group was that the idea of contingency management, of something to work towards, was something that they thought had some value, but that there should be flexibility in relation to people's own goals. So, Andrew, I think this is yours to talk a little bit about the criteria overall. And you're on mute.
Again, so when we sat down as a group, we sat down and looked at some of the criteria. Because I mean, we could talk around in circles all day long, but we really had to come up with what the criteria, and all of them really spoke to safety and to stability. That being the case, we had to have some quantifiable or some measurable factors or criteria, but this not being a simple checkbox of you must meet this and this and this in order for somebody to do it, rather looking at an individual holistically and from a patient-centered care approach. But all of our criteria really did speak to, is an individual showing stability, and then attaching some eligibility, for lack of a better term, to take-home doses. And what we're going to do is go through, what those criteria look like. The first one that came up really speaks to safety, both for the individual and to the community. And it discusses the ability to store carry safely. And is there going to be an impact to the community? This is the one item where there's absolutely no, everybody was in 100% agreement. So that's to say, does an individual have a safe place to stay? They don't have to own their own home, but are they able to store their carries safely? The other item that was absolutely necessary is a locking device, so that we can protect other individuals in society. We looked at the amount of time on methadone. And when I really had to sit back and reflect back on my time frame, in the first 4 weeks that an individual comes into the OIT program, and I reflected back on my first 4 weeks, did I have any stability in my life? No, I really didn't. I was in the process of getting to a stable dose. I would also say that in this time frame, what you're doing is you're getting to know your physician, and your physician is able to properly find out how to best support you. It's during this time that the group absolutely was in agreement that there should be no carries during this first 4-week period. We did break it down into 2 other categories, and Dr. Wyman alluded to some of them. Some carries, 1 to 3 carries, and after the 4-week period, when an individual, provided they meet the criteria of what stability looks like, may be eligible for some carries, and beyond that period. After 3 months on the program, that's to say after 12 weeks, if the individual meets criteria of stability, that they would be eligible for having more carries. So that's 4 or more.
Thanks, Andrew. That's obviously, it's hard to get away from comparing and contrasting with the old guidelines, but it's obviously allows for starting carries a little bit earlier. We felt that, again, with respect to safe management of carries, it was important that a person be able to demonstrate and exercise good judgment. And so in order to receive carries, a person should not be acutely suicidal, psychotic, or cognitively impaired. And when those conditions clear, of course, they can go back to the evaluation in terms of looking at the rest of criteria and moving forward. There might be other mental health conditions or other situations that come up this is not entirely comprehensive. We spent a lot of time talking about stability, recognizing that certainly looking at the literature, a lot of the criteria that have been used to discuss stability are very challenging for people who use drugs because they often have histories of criminalization and challenges in terms of social determinants of health. And so we try to operationalize stability by looking at the individual's living situation, relationships, ways that they manage their daily activities, whatever those are that are relevant to them. And also this idea of mutually determining goals and how someone is doing with respect to progress towards their own goals. And we recognize that there are people who can be very stable and also using substances. So there's not necessarily a direct relationship between the two. And that offering or having access to carries is important because it can help people to build stability in those areas. So essentially, people who are not stable or whose stability is unknown would not be in a position to receive carries, but when their stability is in that developing stage, they could be eligible for that lower number, and that higher numbers of carries are typically appropriate for people with more consistent stability over time. Again, all of these things being considered, not any one, sort of in the absence of the others.
We looked at the criteria of missed doses. That's to say, for an individual who's trying to build stability in their life and with a stable dose, missing any doses is always a barrier to building that. So when I thought back on my own experience, when I was missing a dose, it was the most common reason that I would seek out street drugs or purchasing illicit methadone off of the street so that I wasn't in withdrawal. So we outlined some expectations for individuals eligible to receive carries. That's to say that for an individual in the some carries category, receiving 1 to 3, the individual should not be missing more than 2 doses each week. Ideally, we want individuals to never miss a dose. And then if an individual is receiving the more carries, that's to say more than 4, doses should rarely be missed. So possibly once in a week. And this is where some clinical judgment comes in. I found myself really battling in this spot because it's kind of a double-edged sword. I mean, I miss my doses because I don't have a carry, but I can't get a carry because I'm missing my doses. So it's a situation in which where if I'm missing doses as a result of pharmacy issues, as a result of work, we're meeting with my physician, and physician having the ability to use their clinical judgment would be beneficial.
And then do you want to speak to missed appointments too?
Yeah, and this, this one here, Dr. Wyman, is one that I really battled with myself. I had to reflect that this is probably was one of the greatest barriers that prevented my my physician or my doctor from being able to support me. That is to say, I often missed appointments, which really spoke to my own stability not really being there, or me not living up to, I guess, what I would consider as a partnership between a physician and a patient. The appointments allow me and my doctor to first and foremost build a mutually trusting relationship. It allowed my doctor to, we want individuals to be able to be meeting with their doctors regularly, whether that be on a weekly or a biweekly basis, or whatever frequency is set up. But it's during that period that the physician's able to assess an individual's overall stability, potentially adjusting dosing if that's necessary, so that this person is able to achieve the stability that's required for eligibility for carries, as well as assisting the individual in achieving their goals. And that's not going to happen if we don't have regular connection and open communication with a physician. Considering all these factors, we as a group determined that an individual should rarely be missing appointments, and that's to say they should be at least attending 3 out of 4 of their appointments.
And I think you started talking about, what goes on in those appointments and what makes them a conversation and what facilitates communication. And hopefully this process helps to support elements of that in terms of reducing, the expectation that everything comes down to abstinence in terms of carries. So we looked a lot at substance use and some of the risk factors around substance use, things that made substance use riskier with respect to carry management overall. And I think, to summarize, what we felt was that people who use substances in higher risk ways that impact their health and well-being, including blackouts or frequent overdoses, people who attend appointments intoxicated or sedated, demonstrating difficulty managing their substance use and judgment around it, are not in a position at that point in time to be receiving carries. People who are using substances can be eligible for carries, again, starting initially with this lower number in the 1 to 3, if they're using in ways that don't impair their health, well-being, or safety. So again, we would expect people not to be having blackouts or periods of memory loss, frequent overdoses. And people could be eligible for smaller numbers of carries if they're using, including occasional injection drug use. But recent overdoses, as in the last month, would be concerning. That would be an exclusion criteria. And then typically higher numbers of carries, so 4 or greater, would be for people who are not using substances in high-risk ways, using infrequently in lower-risk ways, not impacting their overall stability. Similarly, the purpose of urine drug tests should really be to help to inform a shared understanding of how someone is using and communication and openness within the relationship. We're not going to talk today about the frequency of urine testing specifically. There are new documents that look at a lot of the technical details around urine testing. But what we felt was really important was that any urine testing be used in the context of decision-making and a conversation, that urine drug tests should not be done on an arbitrary schedule, that they should never be supervised, and they should not be a requirement to receive a prescription renewal. But what's important is that they reflect the person's self-report of their use. And so people whose urine shows evidence of tampering or that they're not taking methadone would not be ready for carries again at that moment, because that would be concerning about how they were managing carries or their judgment and safety in using them. People whose urine samples showed methadone and showed evidence of substance use consistent with their own reports, again, assuming that the other criteria for some carries were met, that would be totally appropriate. And that for people receiving higher numbers of carries, we would expect that those tests be generally negative for unprescribed benzodiazepines, opioids, and stimulants. So all of this is supposed to be considered within conversations, regular visits that look at how the person is doing, not just with respect to their dose or carries, but in a more global sense. There are lots of things that we know need to be addressed to make care more person-centered that we won't talk about today in the interests of time. There's no specific weighting of these criteria other than that safe storage is really required for any level of carries. And again, we expect that the clinician will look at the person and their circumstances more globally and consider other issues that might be pertinent. Where they live, how challenging it is to get to a pharmacy, what are their responsibilities in terms of work or caregiving, what other exceptional situations might be coming up in terms of emergencies or travel. And use those, the criteria and what's known to look at when to start carries. We expect that carries could be increased at 2 to 4 week intervals rather than 4, as long as the person is continuing to meet the criteria and do well within that range, and then hopefully move towards the next range. Similarly, that if someone is having more difficulty managing their carries or difficulty meeting those criteria, then carries would be paused or reduced, again, until someone is able to meet them and move forward again. Situations that would warrant immediately returning to witness doses would include lost or stolen carries or signs of tampering or diversion. And we really felt that it was important that there be a carry agreement, not a contract. This isn't a legal document, but something that really helps to make explicit the expectations for both providers and for people receiving methadone carries. And I think, you know, we may have a chance to talk in the groups or later on about how to make sure that as we move forward, that people receiving methadone are aware of changes and able to talk about those with their providers. There are a number of ways that we need to be careful about communicating with pharmacies, especially given changes that pharmacists may not be familiar with. Again, these are within the document. And I think that within the interests of time, we should break into our groups. Again, this summary is really intended to be a summary, sort of the cheat sheet, but not to replace the discussion, the communication, and the relationship that develops in the ideal world between the person on methadone and their provider. So this is in the document and also I think in your chat. And I hope that what we can do is break into groups now. I'm not sure that we'll have time to come back together into a large group, but I hope that we can have some conversation. And I think this will be the beginning of discussion going forward. And we really welcome feedback. So I'm sorry that I'm not focusing on the chat and comments right now. I hope to, let's go into our groups and hopefully we can have some of that discussion there. And if not, happy to continue this either on the platform and in other formats. So let's go to our breakouts.